Good afternoon, and welcome to the Beyond the Blueprint webinar series. This series empowers health IT professionals with the latest insights, strategies, and design principles required to seamlessly integrate digital tools within their projects. Whether you're embarking on a hospital remodel, constructing a brand new facility, or undertaking a targeted renovation, technology and innovative design are playing an increasing crucial role in shaping the future of healthcare delivery. My name is Greg Malkery. I'm the Managing Director at Spyglass Consulting. I'm also the host for this series. Joining me is my co-host, Keith Washington, a renowned serial entrepreneur and respected board member at Companions in Courage. Keith, do you have any opening remarks?
Yeah, Greg, thanks. So as you said, Beyond the Blueprint is a conversation about design, and we think about design as managing complexity, and that a good design really helps an organization focus on their mission, helps them be flexible with their plans, and then also helps them to be transparent in their communications as they address opportunities and challenges for their staff and patients looking for leadership in managing change to adopt new processes, workflows, technology into their world. So really looking forward to today's conversation.
Great, thank you, Keith. Well, I'm also pleased to introduce our guest speakers, Evan Pankey and Jessica Yang. Evan's a lean startup entrepreneur with 15 plus years of experience in digital health, ranging from building electronic health records to care at home platforms. Jessica is equally as talented as an entrepreneurial product leader with a doctorate in nursing practice. She has broad experience ranging from bedside nursing to clinical operations to software design and IP creation. Evan and Jessica, welcome to our webinar today. Would you guys like to tell us a little bit about yourselves?
Sure. Thanks, Greg. So I'm Evan, and my background is in product management. I actually got into this field from medicine. So I was in medical school and wandered my way into medical informatics and have been building platforms for electronic health records and improving patient care ever since.
And I'm Jess Yang. Thanks for having us today. So my background is in nursing and clinical operations. I have been really passionate about keeping patients out of the hospital, reducing readmissions, and treating them in their home for my entire career, which led me from traditional healthcare settings into more innovative environments such as hospital at home.
Great, thanks guys. Now before we dive into our discussion, I want to express my gratitude to our valued sponsors, Storage Systems and Simplify Medical. Today we're fortunate to have Lars Anderson from Storage Systems here. Lars, perhaps you can share a brief welcome.
This is Lars Anderson with Storage Systems Unlimited. We're a distributor of a number of different storage items, including telehealth carts, partner with our good friends over at Simplify. So looking forward to a nice education here on how things are developing and where we're headed.
Great, thank you, Lars. Now during today's webinar, Evan and Jessica will explore how hospital at home is transforming healthcare delivery by providing hospital-level care directly in patients' homes. They're going to explain the advantages of home-based care. They're going to provide insights in how top healthcare organizations are successfully implementing and deploying these solutions. And then they're also going to examine the implications of hospital at home within the broader healthcare landscape. So with that, why don't we get started? Evan, Jessica, what exactly is hospital at home, and why is hospital at home becoming an important part of the healthcare landscape across the U.S.?
Yeah, so hospital at home is the practice of providing care to patients who would typically be treated in an inpatient setting, but doing it in the home setting. So they would fully qualify to be in the hospital. So this can be a wide range of conditions, but they have to meet certain criteria to be in hospital at home. So it is not traditional home care. This is super important because in healthcare today, many of our hospitals are at capacity and extremely resource constrained. So building new buildings and facilities is not cost effective, but the space is limited to take care of more patients that are looking for care. So what Hospital at Home does is it alleviates that pressure on the healthcare infrastructure, and it also allows patients to be treated in the home setting, which is their preferred site of care, which can be more personal from a healthcare perspective and more cost effective.
All right. Evan, can you discuss the impact of hospital at home on patient outcomes and overall patient experience?
Let me pass that one to Jess.
Yeah. So patients who are treated in the home tend to experience less hospital-related complications. So things that we call like nosocomial infections, which are infections that are acquired from the hospital setting, those are basically almost eliminated in the home care setting. Also things like falls that can be really devastating to patients are much, much less in the home because the patient knows their home environment so well. They know every turn of the hallway, they know where every rug is. In the hospital, patients can get disoriented or they're not familiar with the way the floor feels and they experience more falls. So overall, the home is much safer for patients. From a clinician's perspective, observing patients in their home environment can give them insights they would never get in the hospital. So when a patient comes into the hospital, we structure their day for them as a clinician. We give them meals that are prescribed. So everything is very regimented. When you treat a patient in their home, you get great insights into their day-to-day life. So what food do they have in their cabinets? How are they preparing food in their kitchen? What are the barriers that they have in their home care environment? So the ability to give patients that personalized care is much better in the home. Also, patients, they like to be in their home. They're with their pets, they're with their family members, and it can be really hard for family members to go into a hospital. They have to deal with traffic and parking and all of those barriers where in the home setting, they can just pop in and out like they normally do. So overall, it's a much more relaxed and it's a good space for patients to heal when they're in their home.
Yeah, the core principle is human-centered design, and we're really centering this care model around the patient.
Great response. What effect has hospital home care models had on healthcare delivery staff? And are there specific hospital systems that have successfully deployed these care models?
Yeah, for the hospital staff, Hospital at Home allows for greater job flexibility. There's options for doctors and nurses to work remotely that were never there before. So this can lead to higher job satisfaction and more retention for those staff that didn't have these options in the past. There are many hospital systems that are leading the way in Hospital at Home. Health systems like Mayo Clinic, Kaiser Permanente, Cleveland Clinic, UMass Memorial, Atrium and Advocate. These have really robust hospital at home programs already. And oftentimes they are treating kind of the equivalent to a hospital unit that would be in the brick and mortar. They're treating that many patients in the home care setting, if not more.
Awesome. Well, what are some of the key challenges as you're scaling your hospital home program from a pilot to a fully operational model, and what's entailed with that? And also give us an idea of what would be considered a fully operational model. How many simultaneous patients would you have on service who may be remotely in their home?
Yeah, that's a great question. So I would say that Believe it or not, care at home has been happening for over a decade. But it's just kind of articulated, it's been since the pandemic that this model has really grown under some of the policy changes that were involved. So I would say that the industry as a whole is out of the pilot phase. It's been demonstrated that care at home works. The challenge at this point is a hospital system's level of commitment to growing these programs. And it really comes down to people, process, and technology to support the changes, and the leadership perspective on growing this program. So once that leadership change management is in place, then these programs can really be effective. The opportunity is changing almost how everything is done in the hospital, because we're talking about what happens in the emergency department, how physicians and nurses and support staff work together, going all the way down to paramedics who are in and out of the hospital with these patients. And then same thing on the hospital floor, how that's managed, how discharge is managed. So all these changes have to be supported by people, process, and technology for programs to be effective and to scale. I would say that at the current state, program is pretty robust if it can have an average daily census of about 5 patients on in the program per day. And that sounds like a low number, but all the change management to get to that number is actually quite a challenge. And there are larger health systems that have actually activated multiple sites of care to get to higher numbers. We've seen numbers in the 50s and the 70s, and some organizations that Jess mentioned are targeting numbers as high as 100 across their system. But that's really made out of sites that are in the range of 5 to 15, I would say.
Great, thank you.
So I've got maybe a follow-up question for Jessica. So when you were talking about safety in the home care setting as being improved, sort of things like fall risk, and then even like in the personalized care, the ability to deliver personalized care to home, that sounds like really compelling reasons to take advantage. Do you have a sense of, say, of the number of patients that qualify for hospital and home versus the number that adopt it? Have you got sort of a thought on that? And is what maybe on a percentage or just some numbers that would say the ones that say yes versus the ones that say, no, I'm just going to stick with the traditional care setting?
I would say most patients that are offered the option to be treated at home say yes. The current constraints around treating patients in their home is more on the payer side. How do you pay for it and who qualifies? But the number of use cases for the home hospital at home setting is really quite large. We can take most patients that would qualify for a medical surgical floor, with a few exceptions of things or treatments or interventions that need to be done in the hospital. But with like a few exclusions, most things can be done in the home setting. So the market for hospital at home is quite large, and patients do prefer it.
So let's say the ones that are confused or whatever concerned, I guess, what are some of the misunderstandings that they might express their objection to say, no, I don't really want to have the home care?
They may have trepidations about using technology. Could they operate the technology in the home or whatnot? A lot of the technology, the way that we design it or put it forward, we make it very patient friendly. So sometimes just showing them what the technology looks like and giving them an orientation to the program helps. The other thing patients think about is, will I get the amount of support I need in the home? And when they are in the hospital, they have access to people all the time. So kind of explaining to them the amount of people and how often they come into the home is really important. Also, with the use of technology in the home care setting, patients can often tap a button and speak to their nurse right away. Whereas in the hospital, they press the call bell, and then it gets routed to the nurse eventually, and then the nurse eventually comes in. So there's a bit of a time gap. So once we explain these processes, often patients think, oh, I actually have more access to my care team than I would in the brick and mortar hospital. So a lot of this is around orienting patients to what this potentially could look like for them in their home setting.
Yeah, so just to follow up on that, that seems like the opposite of what I would expect. I would think in the hospital, when you you hit the call bell, you're going to get a response. I guess what's the advantage in the home? How does that work? What's the technological advantage that allows you direct access to your nurse?
A lot of these programs are leveraging a medical command center model where the medical command center is virtual. And okay. Patients can tap into that whenever they have a question or a concern, so they can tap a button and they get in touch with their care team right away. And then the actual physical hands-on care is dispersed throughout the day as they need it.
Great, thank you.
It's a fundamental change on how nurses work and operate, and Jess has been a leader in that change. So in this model, the nurse is really the quarterback. They have the overview of what's going on, who's been in and out of the home, the status of the patient, and versus on the hospital floor where they're in and out of patient rooms, not only having to know what's going on with patients, but also actually being the hands-on delivery of care. So the role is changed when it's virtual because there are other folks that are going in and out of the home.
That's amazing. That's great to hear.
Evan and Jessica, how does hospital at home technology solutions, how do they integrate with existing EHR technology, whether it's Epic, Cerner, or Meditech?
So there's definitely diversity in vendors and how they integrate into these programs. So physicians and most nurses are pretty much ensconced in their electronic health record. If you ask them, they'll say, I want to do everything inside my electronic health records. And the vendors in the industry are trying to support that desire. But in order to have streamlined care in and out of the home, it does require interfaces. So you have technology in the patient's home, a tablet, a blood pressure cuff, or even a patch. That data is being digitally transmitted and it can get back into Epic. So most of the vendors, there's probably about 5 or 6 in this space, can integrate those results back into Epic. And many of those vendors also get demographic feeds about the patients, so they know which patients to send the results back. I'd say those are the most common integrations into Epic, is around demographics coming out and then results from the patients from things in the field going back into the Epic electronic health records. There are certainly vendors that go beyond that, but I'd say that's kind of like the most common integration that happens.
I just want to halt right here. Tim, I know we have a loud blower in the background. Is that preventing us from getting a decent quality sound?
Yeah, Greg, I hear it too. I think we can fix it in post. Don't worry about it.
Great. Okay, thank you, Tim. What role does AI and machine learning have in enhancing effectiveness of these hospital-at-home care models? AI certainly seems to be the rage. Has it made its way to hospital-at-home models as well?
So AI and machine learning are definitely trends in the hospital-at-home market and how the market is growing. So essentially, you have to have an interface established to support continuous improvement in the system with machine learning. So it's really about continuous improvement. So if results are coming in and out of the system, vendors are starting to build technology that they can improve recommendations for changing or augmenting clinical therapy. And there's also use cases around improving the flow of clinical logistics.
Awesome. What about some of the current reimbursement? I know, Jessica, I think you talked earlier about payer reimbursement. How does that implement, or how does that impact the implementation of these programs?
Yeah, it's a great question. So, you always need someone to pay for the care. That's at the core of everything. But there's a really great opportunity called the Medicare waiver, the Hospital Without Walls waiver program coming out of CMS, which allows patients to enter hospital at home through the emergency department. And with that, there's a requirement for 2 home visits a day in the hospital at home program. This originated during the pandemic, and it has been extended to date. So of course, at the time, hospitals were extremely full and resource constrained, so CMS allowed hospital care to happen outside of the brick and mortar facility. This waiver is up for renewal for 2025, and the current bill, they're proposing a 5-year extension to it. So this is great news. This is great news for us.
How many hospitals or health systems across the country have approval for hospital at home or hospital to home programs?
Through the waiver?
Yeah.
That's a great question. Evan, do you know that off the top of your head?
It's quite a large number. This really took off during the pandemic. And the regulations have been pretty straightforward, and a lot of hospitals are able to qualify. I think the number is in the hundreds at this point.
I think I saw something in an article was about 350, but that might be old data.
Certainly possible.
How does policy influence the scalability and effectiveness of these programs?
It has a huge influence. So beyond Medicare, there are other payers that are interested in the space. So some innovative payers like Humana, they're looking at 30-day bundled payments, and that can really help the sustainability of hospital at home programs. And with a bundled payment approach, this really gives clinicians flexibility to provide a very holistic approach to care as patients transition from kind of that acute care hospital stay back into their daily lives. So there's a very high risk period of time after patients leave the hospital that they have a lot of questions or concerns, or maybe they are experiencing a new symptom that's not a problem, but they're not sure. So with a 30-day bundled payment, clinicians can extend their level of focus beyond the acute care stay and really help patients get comfortable with their new normal and transition back into daily life.
Yeah. And we're in a great point in time where the technology is really not the rate limiter. It's really the policy and reimbursement framework. So we have got the Medicare waiver in place. It looks like it's going to be renewed. There's experimentation, as Jess mentioned, with 30-day bundles. There are health systems that are really accountable care organizations and vertically integrated. They can already flex to provide the best setting of care for the patient and technology to support that. So really, the payment models are now the rate limiter to the growth of care at home.
Great, thank you, guys. What are the current controversies in the field of hospital at home, and what are you currently doing to work on addressing some of these controversies or challenges? I know you're working with some of the leading organizations in the country that are involved with these types of programs.
Yeah, that's a great question. So one controversy is insourced versus outsourced vendors or supply chains. So a lot of hospitals, when they start out, they want to use as many of their internal resources as possible. So what they'll launch the hospital at home program, and they'll say, could we use all of our home care staff to support these patients? And oftentimes it's a good start, but it may not be enough. You may have to train those home care providers a little bit differently to these new workflows, and you may reach capacity quickly because you're needing more visits than traditional home care would support in their regular workflow. So oftentimes health systems will start with an insourced approach and then kind of move towards, we need more support for these programs and ask for help from outside vendors as well.
Another one of the topics of discussion is who are the types of workers who are best suited to do this care. A lot of hospital systems have nurses on staff that can go out into the field. And there are a large number of states that are also activating paramedics that are doing mobile integrated home health as a service. So there's a lot of diversity of opinions on the effectiveness of either clinical type and the training pipelines. Like there's a shortage for healthcare workers in general, but those two nurses who go out in the field and paramedics are some of the leading areas of opportunity and innovation and staffing for care at home.
One thing you brought up earlier, Jesse, you're talking about the integration with Epic, but is there integration with other types of technology systems, which actually might create different silos for servicing patients in their homes?
Yeah, I mean, so that's a great question as well. So the use of major electronic health records such as Epic, it is a topic of conversation for every hospital at home program. So for health systems, their investment in their electronic health record is a large one. They have put a lot of money and time into making it exactly how they want it, and all of their clinicians are trained on it, and clinicians prefer to work in that one-stop shop of their EHR. The reality is to kind of decentralize care and work in this semi-virtual model. Oftentimes, you need additional technology to support the new care model. So oftentimes health systems will say, I want to do everything in my EHR, can I? And the answer is often no, but if they're starting at small scale, it may take them, through their first few patients, but to really scale out these programs, they often need to integrate with additional technology solutions to really give both the clinician and the patient the tools they need to be successful in the model.
So I have some follow-up questions on the approach that you were talking about in terms of the organizational staffing, where you've got some concerns about the captive versus the contract worker or the insource outsource that you were talking about. I guess what do you think about we always think about design as some vision for the future where there's a more desirable combination of things. So if we had a future state where, let's say, rather than the kind of exception, it was more of the standard of care that hospital at home was the majority. So instead of there's dozens, there's like hundreds or thousands of patients at any point in time. I guess how is staff going to think about that? So let's just say set aside whether the clinician, say the nurse or the physician, whether they're captive or contract. I guess how do they think about that model? What are you hearing from them? Are there certain types that would prefer it this way, or I guess just overall in that scenario, how do you think clinicians are going to react?
I think it's really a numbers game. So at low scale, when you're talking about seeing 5 patients a day, a lot of the health systems do have enough of staffing that can go home, that they can support it. But when they're inside those systems, they are required to be fully credentialed by the hospital, fully authenticated inside of Epic. And then when you get to larger scales, those things often become bottlenecks. So I think to your point, as the system grows, I think there'll be a delineation between what the hospital's area of expertise is and where vendors external to the health systems can help provide services at scale. And we're starting to see movement of some of the leading vendors to take up that space in supporting more distributed supply chains to allow higher scale for care at home.
Oh, that's really interesting. So yeah, so you're saying before one of the key barriers right now is the payment model, but let's just assume if that's all fixed, then that's the next one, right? It sounds like the kind of the how it's going to get distributed, the credentialing, the approvals for staff to be part of this.
Yes.
Is that, yeah, okay,
That's right.
great.
Well, I think that's all we have time for today. But Evan and Jessica, I want to thank you for sharing your insights about how hospital-at-home programs are helping provide hospital-level care directly in patients' homes. You explain the advantages of home-based care. You provide us understanding of how healthcare organizations are successfully deploying these solutions. And we examine the implications of a hospital at home within the broader healthcare landscape. For those of you in the audience who are not familiar, I represent Spyglass Consulting. We're a product and go-to-market advisory firm focused on disruptive technologies and growth opportunities within the healthcare and life sciences industries. Spyglass proudly serves over 250 leading entities ranging from technology companies, management consultancies, to healthcare providers and investment organizations. We've published more than 30 market research reports on a diverse set of informatics-related topics. To access our extensive library of paid research and to gain a deeper insight into how technology is reshaping healthcare, I encourage you to visit our website at www.spyglass-consulting.com. Well, Evan and Jessica, thank you very much for your time, your insights and perspectives, and also to our sponsors, Storage Systems and Simplify Medical, who made this conversation possible. Evan and Jessica, would you like to provide us with any closing remarks?
Sure. So Jess and I both work at Growth Excel, which is a technology incubator, and we're really focused on improving care at home. So we're open to helping health systems as they figure out these technology challenges in healthcare in the home and beyond.
Jessica, any final remarks?
Thanks for the conversation and having us here today. We feel very strongly that hospital at home is the future, and glad to get the word out there.
For audience members who want to reach out to you guys, how would they do that?
It's through the Growth AXL website. So that's growthaxl.com. That's the website. You'll find us there.
Great, thank you. Keith, would you like to share any final thoughts on today's webinar?
Yeah, I really appreciate this. I was very encouraged by the clarity of how well you guys articulate the benefits of these programs. Part of our mission on Beyond the Blueprint is to continue to talk to thought leaders about what does patient-centered value-based care look like, and this really just frames it really well. So very encouraged, really inspiring. So I really would love to have you guys back to keep this conversation going.
We'd be happy to.
Absolutely.
Well, at Beyond the Blueprint, we can look forward to continuing this conversation, and we will definitely be inviting you guys back for Chapter 2. So thank you very much for your time today.
Thank you.
Thank you.